so much has happened in the last 10 years. I did an
Yeah.
interview a couple of years ago with Dr. Egner, and if you listen to that and you go to now, the guidelines have changed, everything's changed. Give me the history though in one quick, quick blurb.
Yeah, well, I mean, I think that's a really great question, and where was focal therapy 10 years ago? Where is it now, right? But I think that question really to be able to understand why we're talking about focal therapy more all the time now is I think really kind of boils down to really three major inputs, right? And one of them is going to be biology, one of them is imaging, and one of them is technology. When we talk about biology, David, what we're really seeing is kind of a stage migration of more localized treatment disease as well as lower volume treatment over the last 20 years. So cancer is no longer kind of T3 disease that we're seeing for the most part. It's a lot of T2 disease and lower volume, not necessarily the whole gland, maybe more partial gland, right? And so that's really due to PSA screening, right? And that's a big advent of that, and that's really what's changed that biology disease we're seeing in our clinics. Secondly, it's also imaging. 15, 20 years ago, you talk about prostate MRI, it was kind of just like a pie in the sky idea. It was being used in maybe some major centers, but really not ubiquitous like we do every day here, right? And that's really changed the game for the use of focal therapy now than it was, 10, 15 years ago. You know, Back then we were using saturation biopsies, trust biopsies to really be able to, find patients that are eligible for focal therapy. And, there's a lot of recurrence issues and they were just understaging the patients, not getting a good sense of what was going on in the prostate. So prostate MRI now, we're getting a really, pretty clear idea of A, where the cancer is, and B, if there's other areas in the prostate that, could potentially have cancer down the road as well. The trials that have really shown this, one of them is Precision, the other one's the Pivot trial. Obviously, that was more long term, and then there's the Trio trial that came out in New England Journal of Medicine probably about 2-3 years ago that showed there's less upgrading on final pathology when you use MRI and biopsy. So I think that's really changed the game in terms of now we can better decide which patients are eligible for focal therapy and which are not. And
That's
then
a key
lastly,
point, right? Because if we're concerned for, missing higher stage disease, then focal therapy kind of becomes a little bit more of a question mark. But in the age of MRI, much better.
it's much better, right? And I think that's really what we've been able to show with high level data, not just our kind of anecdotal data. And
Right.
just lastly, the last one is technology, right? Technology has improved. 20, 30 years ago, again, we were really only cryotherapy. Cryotherapy has been around for so long. But you look at kind of that field of what we can use to kill tissue now. We're using high intensity focused ultrasound. We're using cryotherapy. We're using IRE, right? Irreversible electroporation. We're using focal laser ablation. We've just that whole area has expanded so much, and now we kind of can pick and choose the technology we want to use to really be able to treat our patients. So that's kind of what has changed over the last, 10, 15 years to really what has really brought focal therapy more in the forefront nowadays.
Understood. And so with all the things that you're using, MRI, ancillary studies, if you use them, who are your ideal candidates? Who are you more inclined to, obviously it's all shared decision making, but who are you more inclined to offer focal therapy to?
Yeah, and I think this is really the key point of when we talk about focal therapy success. What does it really look like and what is it predicated on? It's really patient selection. And anyone who says otherwise really, I think just is not really going to be nuanced in what really matters, right? So, for me, the ideal patients for focal therapy really are going to be intermediate risk NCCN patients. So grade group 2, grade group 3 disease patients, mainly unilateral disease. If they have bilateral disease, I think for focal therapy, they're not going to be a good candidate. Ideally, we want to see MRI visible disease, and that's going to help us in terms of our surgical planning during focal therapy. And then lastly, this is a little bit of a per practice situation, probably PSA less than 20, and that's really based on the intermediate risk criteria on NCCN. PSA of all those options, I think are the least important of them all, but it's something that I use at least to help stratify my patients in terms of which ones are good candidates and which ones are not.
Great. And so yeah, so the data that support these and use especially the patients that are included are intermediate risk. What are the functional and oncologic outcomes of those patients? And
Yeah,
what does the
so
data show us?
Yeah, so I mean, I think the data in terms of patient selection really is based on a ton of consensus statements, right? So there's really no set guidelines for the use of focal therapy, and I think that's going to be one of the biggest problems about this field. It's been a little bit of a wild west, and so I think that we're trying to tame that whole concept and to really kind of bring out structured guidelines and how we can really, better select patients and how we can give more guidance to physicians who want to really use focal therapy. But I think when you look at some of that data and consensus statements, there's more and more emerging data. There's the recent HIFI study that came out in European Urology, which was radical prostatectomy versus subtotal HIFU. There's the PRESERVE trial, which is IRE, that's going to probably read out in the next year. There's a 22 Lancet article about HIFU. I think we're seeing high volume data, maybe not sorry, high quality data, maybe not necessarily randomized, but I think in the next few years, you're going to be able to see more and more high level data to really support focal therapy. And I think one of the things we're going to see in all of those trials is really the benefit of the functional outcomes of our patients compared to any type of radical treatment, whether it be radiation or radical prostatectomy.